Hello, everyone. Welcome to this session of the conference. I hope you've been enjoying the other sessions. In this case, we have the fortune of having with us Dr. Grant Christie, who is a senior lecturer in the Department of Psychological Medicine at the University of Auckland, a child and adolescent and addiction psychiatrist who's been working in outpatient and residential settings for over 15 years. He has worked on screening tools and on intervention tools for mental health and substance use in the area, and has shared a number of resources that you will be able to explore after his talk as needed. And so the way we're going to do this is I'm going to pass the floor on to Grant. And then I'm going to facilitate a Q&A. And before that, I just realized I may as well introduce myself. I'm Daniel Vigo. I'm a psychiatrist and faculty here at UBC, and very happy to be hosting this session. So, Grant, please take it away.
Thanks very much for that kind introduction, Dr. Vigo. You've pretty much heard about me. I'm ringing in here from New Zealand, and in my office at not at the university. I also work at the CADS Youth Service, which is a youth alcohol and drug service, and it's an outpatient community-based kind of service. And this is, I guess, the setting in which a lot of the research and work developing resources that we've done over the last 15 to 20 years has kind of been done. So it's been, and so I'm here in Auckland, but I'm from Wellington, and which is the capital city of New Zealand, and yeah, as Dr. Vigo is saying, I've worked a bit in Australia and a bit in the UK, but pretty much here's home. So I'm going to try and share my screen now, and I'll just hopefully there won't be any problems with the internet here, but I should have stayed at home because the work internet's not as good as at home, but hopefully you can see that there. So I'm talking today about how I've essentially gone on in New Zealand. Just a little bit about New Zealand. We've got a population of 5 million and reasonably good continuity across. We have a sort of public health system, and there's a lot of sharing of resources, and so it's a reasonably good setting in which to get buy-in from all the different kind of agencies that are working. And so we have reasonably good communication and links with with the other health providers in New Zealand, which means that we can get continuity and consistency across, and so that's part of the setting that's been enabled some of the work that we've done. And so essentially I'm going to be talking about, firstly, the beginnings of our work in screening, and then in brief interventions, and then how we've moved on to put those into a more electronic form, and in terms of using computers and smartphones. So this first slide here is just to set the scene about what's been happening in terms of substance use in New Zealand over the last 20 years. And this, we have something called the Youth 2000 surveys. The first one was done in youth in 2000, and we've had 4 since then. And this graph essentially shows how substance use has decreased in New Zealand young people over the last 20 years. And this is consistent across the world. I think in most Western countries, in any case, there's been a decrease overall. So the most recent survey was in 2019, and there were nearly 8,000 young people surveyed. And at that time, about 23% of them were mainly secondary school pupils that are surveyed. 23% of them had reported using cannabis. About 4% were using cannabis weekly or greater. 10% approximately were saying that they would drink at least once a week, and 22% reporting a drinking binge in the last month. So that's, I'm not sure how that would correspond to where you viewers are kind of based. But I guess the key thing is that we see in the table and in the graph on the right, we see a decrease from 2001 cigarette use being 15% down to 2.6. So really significant reduction. Cannabis use has decreased from 6.5% down to 4%, and binge drinking, we've seen a decrease in that as well. So it's a good news story, and I guess that's the sort of basis in terms of where we've been working in the area over the last 20 years. But still, there are young people who are at risk, and these young people don't really change. So even though I guess our overall across the population substance use is a lot less, there's still this minority of young people who are at risk of going on to develop more significant drug and alcohol problems in the future. And by intervening early and identifying them early, I guess we aim to sort of prevent that trajectory into more problems. So who's at risk? So what we know from the research is those young people who start using early, young people who use frequently or heavily, those with personality traits of impulsivity or thrill seeking tend to be more at risk. Young people who develop tolerance early, so it goes along with heavy use, but if you've got the biology and the availability to use substances and you develop tolerance, you're known to be more at risk of further going on to having more significant problems later in life. Those with a family history of substance use disorder, of course, young people with mental health, coexisting mental health issues, and of course, those in an adverse socioeconomic situation are much more at risk, as we all know. So when we're thinking about these young people, these are the ones that we're trying to target and we're trying to identify. Of course, we want to work across the whole population, but it's definitely this 20 these young people. And unfortunately, this Youth 2000 survey done that we looked at before, it also asks about a lot of health behaviours and how are young people seeking health services and accessing them. And those that we find difficult and are kind of more at risk are unfortunately the ones who are unable to see, usually the ones unable to see a health professional when they need to, and they're from small towns, from the country, low decile schools, so that's schools in poorer areas, and rangatahi Māori and Pacific youth. Of the young people who had seen a health professional in the last year, 80% of them had access to health service, but unfortunately fewer than half of the students who had seen a health professional were at the time assured of their confidentiality and had the opportunity to talk to the health provider in private. And coming from the area of youth substance use treatment, I'm very cognizant of the fact that, you know, what a young person says to a health provider is not necessarily what's happening in their life. And we need to have a setting where young people feel safe to share what's going on if we want to we want to get meaningful information about what they're getting up to. So I talked about, this is sort of further scene setting, if you like, and I talked earlier about how the Youth 2000 surveys have been repeated 4 times, and I was involved in evaluating some of the data around youth substance use in the 2012 study. And when we're talking about youth substance use, it's what's concerning in a 14-year-old young person is different from that substance use that might be concerning in an 18 or 19-year-old. Obviously in New Zealand, the drinking age is 18, and so we're not so concerned about an 18-year-old drinking as we might be a 13 or 14-year-old. But how do you unpick this when you have the sort of standard questions for this whole range, developmental stage range? And so what we did is looked at some of the questions that were asked in the survey, and we asked a group of experts and practitioners in youth substance use about what would be the level of concern that that they would have, what would be an identifying set point when they might be concerned that the person would need some kind of treatment. And so we on the left table here, we identified this very high or problem use for under 16s across these items, so drinking several times a week or more, having a binge drinking session, or using marijuana once a week or more, and etc. And for those over 16, we also identified the criteria which were a little bit more, if you like, more significant, indicative of more significant problems. So we ended up dichotomizing the sample into those young people who fulfilled criteria for this, what we call problem use or very high use, and those who didn't. And what we found, and in the table 11 here in the right-hand study, is that the students with very high use, so there was 887 of them out of the overall sample of 6,000 or so. They had seen a family doctor, been to A&Es. They were attending family planning or sexual health clinics much more in some cases than the students who weren't using or didn't meet the criteria. But down the bottom here, we see that only 5% of them had accessed an alcohol and drug service in the last 12 months. So what this tells us is that there's young people out there who are reporting and have significant substance use, but they're not getting into where they need to be, which is a substance use service. However, they are presenting at different health services. And so I guess this is where the importance of screening and brief intervention comes in play, because if the other health services were better prepared to identify these young people, we might be able to get them into services more easily. So now I'm going back to 2007, where this has always kind of been the case, I guess. And back then, when I was setting up our CADS youth service, we were looking around for screening instruments that we might use for both screening and outcome measurement in our service. And we kept coming up against problems with established instruments. Some of them were a little bit long, some of them, a lot of them were just for alcohol or just for other drugs. And really, when you're with a young person, they're polysubstance users, they tend to use lots of things. You don't want to administer different screening instruments for different drugs. And so, and at the same time, a grant came available to develop a screening instrument. And so we embarked on quite a lengthy and project to develop what ended up being called the Substances and Choices Scale. And there's the reference to that is there below. And then the scale that we ended up developing is there on the right. And how it works is a young person will be given it or be read it. It will be read out to them by a clinician, and it asks in part A, it asks how often they've been using a variety of substances over the last month. And then in part B, it looks more at behaviours and harms related to their substance use, and they answer those either not true, somewhat true, or certainly true. And at the time, this was based on the STQ, which is a strength and difficulties questionnaire using the same format. And the idea was that the two instruments could be used together as the Strengths and Difficulties Questionnaire, which is a youth instrument screening outcome instrument for mental health, doesn't have any alcohol and drug reference to it. So basically it's a one-page self-report questionnaire. It was designed, tested, it's got good validity and reliability. It screens for alcohol and drug use and related harms. It engages young people to think and talk about their substance use, and young people reported back to us in the process of developing it, because we asked for a lot of feedback about it, that they found it useful because it made them think about things related to their substance use that they hadn't, just doing it, scoring it by themselves. And this is great because as a clinician in the area and wanting to, essentially we're in the business of developing insight and getting young people to take the step from just being in the moment and using substances and thinking more about what the potential harms and consequences of those might be in the future. And that's what we aim to do in a brief intervention. And young people were saying when in doing the SACs that process was happening, the beginnings of it was happening anyway. So that was the SACs, and then so we started using the screening tool and distributing that. And on the earlier slide, there's the website where it's available, and it's still available free to download. But then once we developed a screening instrument, the next part of the process is thinking about how can we move on and do a brief intervention. So what's a brief intervention? So I would say it's 10 to 30 minutes of discussion about substance use, targeting harmful effects and impact on individuals. Others might say it can be longer, but in young people, generally that's kind of what they have tolerance for. So in it, you'd use a screen to identify problems, you provide feedback, advise to reduce use, and advise on advise on harm reduction strategies. It involves personally linking information that they provide about their current problems to any information that you provide to them. So there needs to be that personal relevance to them. Often provision of resources for them to take away and look at later is really a key part of it. And there's evidence to suggest that brief interventions are effective in a number of settings for young people. So the next part of the journey, I guess, was developing a brief intervention to go along with the SACs screening instrument. And this is available on the website. It's pretty easy to Google, I would say. But essentially, we had we developed a manual and a teaching, training process and worksheets and various things for clinicians to use. But in this case, the target audience, if you like, were other mental health workers, so workers working in child and adolescent mental health services, and also working in what at the time was called CYFS, which is Child, Youth and Family, which is our social welfare system that we have here in New Zealand. And this is a paper that we published looking at the change in attitudes and knowledge in child and adolescent mental health workers following the training that they had in using the SACs to do a brief intervention. So that was the next stage. And here's just a screen jab of a resource that a clinician might use for a young person when doing brief intervention. And essentially it's a goal planning exercise, and you can see on the top left there, the young person decides on what some options and things that they might want to change about their substance use following doing the screening. Then they brainstorm possible strategies for that and decide on them. And essentially they walk away with a goal. And so this is a kind of one of the resources that went along with the original screening and brief intervention package to help clinicians. So that was kind of through up until the late about 2012, 2013, and then so we had most of the child and adolescent mental health teams and quite a lot of the child, youth and family teams using the substance and choices scale and SACS as a screening instrument. Although it was kind of rolled out there, getting actual workers to actually use it is another matter. You can train them, but getting them to actually do it is difficult. And any of you working in the field are trying to get mental health workers to do alcohol and drug work, you'll know what an uphill struggle it is. But we were getting somewhere in the sense of having a tool and instrument and process that was relatively straightforward. But the message that we were getting from primary care, who were seeing a whole lot more young people, was that the current SACS brief intervention as it was, wasn't streamlined enough, and we needed a quicker one. And so we ended up developing what we called the SACS ABC, which is a brief intervention more designed for health settings, so school nurses, A&Es, youth health workers, and essentially it's called the ABC approach because it's based on established Royal College of GP guidelines for smoking and drinking in adults. And so we tagged the SACS brief intervention into a system that GPs and health workers already knew about. And we developed resources to go along with that, and here's some of them. So basically the ABC stands for ask about it, and we'll introduce and do this SACS screening instrument. Brief advice, which is discussing safety, harm reduction strategies, and providing resources, and linking that to the information that you provided to what they've talked about in the screening process. And then the C is referral for counselling or treatment. And again, the SACS yields a score, and we're able to roadmap the GPs and the health workers to, if people are moderate or high risk, to step up, if you like, their intervention. Here are some of the resources that we developed with help from the sector and also from young people. There was definite feedback from young people that the kind of information they wanted was plain. They didn't want, well, essentially they preferred this kind of setting and this kind of presentation. And so this card actually folds up into a small, it's 8 pieces, but it folds up into one and about cannabis and all these different kind of bits of information on it. So that there's about 7 or 8 of those different cards. We made a video to help train workers into providing doing the SACS ABC, and this is again all available online. You can watch that. So the evolution has been developing the screening instrument, developing a screening and brief intervention, then using that in mental health and social workers, and then moving on to primary care. But one of the issues I think with developing resources is that everyone's always reinventing wheels, and it's people, when they need resources, don't know or find them hard to find. And we're lucky in New Zealand to have workforce development centres that cover the whole of child and adolescent mental health, and that's called Weary Workforce for Roro. And so we developed a page on for Roro. It's called Opt for Wellbeing, where clinicians and young people could access all they needed for alcohol and drug treatment. So there's not only the SACS and information about SACS ABC, but also other information about mental health and how to get help. So that was another part of the process, developing that website and getting feedback about that. And I guess this is the beginning of taking something from paper to the electronic sphere. And here's just some examples of what's available on that. There's videos, did you know videos about substances. You can download the pocket cards if you need, etc. Okay, so we're moving now into the electronic sphere, and where do you see most young people? Where are they? Where are they? They're all at school. Okay, and and in New Zealand, for young people in low decile schools, so schools in socially deprived areas, they all have a health check age 13 and 14. And in terms of identifying substance use, this was something that was done sort of only in a cursory way. And we were thinking, if we can get the substances of choice scale into that initial health assessment, we're going to access a whole lot of other people. And so we embarked on a pilot where this is Pupil Web. So this is one of the health IT interfaces that some of the schools in New Zealand use. And by putting the SACs into the system, and at the top here, we have first questions, alcohol, cannabis, other drugs, and the second part of it's obscured there, but essentially the school nurse who would do this would do the SACs with the young people, push the analyze button, and then get advice about what they need to do in terms of the next step. And in this case, this person's been identified, Chris Crustacean's been identified as high risk. His level of AOD problems need further assessment and treatment. Consider doing a HEADS, provide brief advice and pocket card resource, and recommend referral to alcohol and drug service. So we've incorporated it into their health system. And then we evaluated this through a pilot. And we ended up using what we called the ESACs on a sample of nearly 5,500 students in parts of Auckland, that's counties Manukau, and in Canterbury. And so here's just some kind of snapshots of some of the results we had from this. Mean age was 16, so they're quite young. So although in it a lot, there's not that many who are screened or identified as kind of having either substance use or risky substance use. That's because many of them are 13, 14 and 15-year-olds. And so basically those who went on to do, who initially identify that they're using substances and then go on to use the second part of the SACs, which is the one that identifies the harm related to the substance use. There are 6% of them. And of that 6%, or 300 or so young people, 173 of them were identified as high risk. Here's some more results here. And AE, this is alternative education. So not unexpectedly, a lot of the young people who are identified as having risky substance use were out of school. And so when someone is expelled from school, they go to alternative education facility. And here's some of the items that were on the SACs that were endorsed by them. They're wanting to cut down. There's worrying levels of them driving under the influence or being driven by people who are potentially intoxicated. They're doing things that get them into serious trouble, etc. And you can see here the use of alcohol and cannabis. So of this high risk group, the school nurses ended up referring 65% of them to some kind of further follow-up, either alcohol and drug services or in-school alcohol and drug programs, or mental health, child protection, or for further work with the guidance counsellor. So this pilot, the nurses and students reported high acceptability. A lot of them were offered the ABC approach, and 4% were referred. So it was a pretty successful pilot. We were pretty pleased with it. We haven't, the paper for this is currently in prep, but So that's the second ESAX part. Now, I'm running out of time, I understand, but I'll just talk about the next stage. And of course, young people, the main way to reach young people nowadays is via their smartphone. And so the next step was putting the substances and choices scale brief intervention into a smartphone. And the best way to look at this, I guess, is to click on this link here, the Brief Quiz web app, and this takes you directly to it. And I'm not sure if it works outside of New Zealand, but it should do, I think, and you're welcome to use this with young people if you can. It's still in development, but you can easily see how it works. So it's a smartphone version of screening and brief intervention, and there's 6 components to it. And in developing it, we've tried to emulate the process of a face-to-face brief intervention with a clinician by firstly doing screening using the SACs, and then trying to slow things down and get the young person to reflect on some of the things that they might have endorsed in the answers in the brief. And then we provide them with feedback about their score. And we do this by firstly saying to the app says to the young person, well, what do you think a young person who has substance use problems might score? And what do you think just a normal kid who's at school might score? And then they put this on the app, and then we show them their score compared to that, along with the community and clinical norms. There's a section of it to provide harm reduction advice, and then obviously ways for them to get help and self-refer to services. There's a further part to it, which is in development, where the young person will create an account, if you like, and then the account or the platform will get back to them in a month or 6 weeks and ask them to repeat it to see if there's been progress. So here's the brief. I'm not sure I've got time to show you it, but you can, the website's up here, but what these videos play, but what I'll move on to is this, to just show you the part where we provide feedback for the young people. So hopefully this will play. So how do you compare? Before we show you scores, slide to where you think students would. So this is where most young people score in the brief. Young people in treatment score about here higher, and this is your brief score. And then it provides a bit of feedback, and then they push continue. And then here's the brief tips and ways to get help. And I'll just play this quickly. So for each substance and also for safe partying, there's a number of buttons, and they can, if they can choose which one they might want to do, and there's a little bit of advice provided for them there. There's cannabis, other drugs, and then there's a safe partying reduction advice tile as well. Okay. So I talked about a platform, and so the Habits platform is something that my colleagues from the University of Auckland are going to talk about after this session. So Carolina and Sarah are going to present a workshop talking about the Habits platform. And the idea is that for New Zealand, a range of online and app-based mental health and addiction interventions are in one place, and that this platform is, and the brief would be sitting on that platform also. And here we'd be able to collect data confidentially and then evaluate things in real time. So just in the last 2 minutes, another app that I've been involved with, which will also hopefully be placed on the Habits platform, is called TuneIn. And this is, again, both alcohol and drug and mental health, but it's essentially a goal planning app where a young person will choose what they want to work on, and the app will remind them each day that they've chosen to do an activity, and so that's about their journey. So there's steps along their journey, and then their goal is this. In this case, this person's goal is accepting themselves. They want to improve their competence, and they're going to do that by using self-soothing and focused techniques, which in practice take time out alone for 15 minutes a day. So this is a kind of app that rewards the young person for their steps that they've taken with music, essentially. So my final thought. So it's all very well having screening and brief intervention, but they need to be complemented by accessible and effective services. And I guess another part of the work that we've done is to influence and the creation of youth targeted, standalone youth alcohol and drug services across New Zealand. And originally 20 years ago, the CADS Youth Service where I worked was one of about 3, but we now have probably 20 across different parts of New Zealand and increasing. So that's something that's been gratifying. I guess we can't not mention COVID, but what we've noticed with our team is that it's sped up the acceptance of telehealth and Zoom, etc. Although there's a digital divide out there, and those young people who need us the most still don't really have the greatest access to technology. We're getting there, and hopefully treatment for all will be more accessible in the future. One of the problems with SPIRT, or screening, brief intervention, referral to treatment training, is we know that it needs follow-ups and refreshers and reminders, and some of the training programs that we've been involved in, we've done that for a year or 2, but they usually it hasn't gone on longer than that, and that really needs to be something that is factored in. As I talked about before, we need to complete some formal testing of these and app-based versions of the SACs, and we're hoping that the rollout via the Habits platform, which we'll hear about next, will enable naturalistic, real-world, up-to-the-minute feedback about its uptake and effectiveness in young people. And the final comment, I guess, is that the addiction landscape and the world in general is in constant flux, and so the tools and techniques that we use will need to change and be updated as we go. And so it's been fun, I guess, to be involved in the sector over that length of time, and to be able to kind of move with the times and try to keep up. But I guess one thing we've learned with developing apps especially is that it takes a long time to evaluate and to develop and evaluate them, and by the time you have, things tend to have changed. So thanks very much for listening. I hope that the technology worked and I wasn't cutting out through that, and yeah, I hope that you have the rest of the conference is great.
Thank you very much, Dr. Christie. And so that was a very, very interesting and thought-provoking presentation. And I wanted to open up the floor for questions from our audience. Any question? You can raise your hands. Is there anyone? Oh, let's just one sec. Let me look here. Yes. Samia, do you have a question there? Do you want to pose it, or do they do it in the chat, or how does it work?
Hi, Dr. Vigo. All of the questions will be able to be on Whova if you're able to see that.
On Whova, okay.
Yes.
Okay.
Oh, Whova, okay, have a look.
Yes. Can you speak to how this screening and brief intervention is used when working with Maori Indigenous peoples, families, and communities? Are findings of the evaluation any different for Indigenous youth?
Yeah, good question. So one thing we've been at pains to do in the development is to make sure that what we're developing is acceptable to the Indigenous people in New Zealand, the Maori, and also the Pacific community. And essentially, we're we had an advantage, I think, with youth in the youth sphere, because although the Indigenous young people definitely have their own, and especially the whānau or the family culture is unique for them, they also share a youth culture with other New Zealanders, and so other New Zealand young people. And so a lot of the feedback we've had is that the young people, the Pacific and Maori young people, don't want special treatment. They don't want a special instrument for them. They want something that is used by everyone. And so we've got that feedback, and we've over sampled Maori and PI young people where we can to make sure that the instruments work for them.
So we have a lot of questions. Unfortunately, we have run a little bit, we've gone over the allocated time. All the comments are very acknowledge what an excellent presentation it was. There's one question that I would ask here, which is, was there parent or caregiver involvement trying to get youth adherence to digital platforms?
Yeah, so I think that's a really interesting question, because one of the key issues with getting consent from ethics to do this kind of research in young people is you need parent consent to do it. But what we know about young people's online behavior is that they do that without their parents' consent. And so there's this, of course we want that, and we'd like to ask families to do this kind of work, but at the same time we immediately contaminate our samples, because the young people who we actually want to access often don't want their families involved. And so so I come from a very sort of youth-focused background, and I'm very sure that young people are able to consent, and in many cases know more about these kind of modes of delivery of treatment than their parents might, and that they have the capacity to agree or not to agree to partake in this kind of research. But our ethics committees don't. And so that's definitely a struggle that we have to contend with in trying to develop these kind of instruments.
Okay. There's people asking about, for you to remind them the name of the app.
Yep, so that's someone's kindly put it into the chat on the Zoom.
Yes, yes.
And I will kind of make resources available on the Hova afterwards. Yep.
Okay, unfortunately we have to wrap up. Thank you very much, Dr. Christie, for an excellent presentation. The workshops that will follow immediately, at least some of them are quite closely related to what you have just presented, trying to provide screening and intervention tools for young people. And so we hope that you and the attendance can naturally flow towards the workshop sessions. Thanks again. Thanks everyone for joining.
Thank you.